Okay, great. So this evening we have Professor Tony Salenza, of course, in emergency medicine, and he's been one of the examiners with the emergency medicine station in the Formative OSCE that you have just experienced. So, Tony, tell us, with this ED station, what do you think were, in general, things that students did well in?
Okay, thanks, Zenki. Thanks for letting me give some more feedback. So the good things that I found from the better students were that they had a nice structure to the history. So the station was a patient with syncope and needed to have a diagnosis made and an ECG interpreted. And those that did well in the history section were able to give a chronological or obtain a chronological series of events about what happened to the patient using open questioning to start with, and then were able to hone in on the potential causes of that collapse. So would ask specific questions about whether it was a seizure, whether it was syncope, and whether it was associated with different potential causes of syncope, like cardiac symptoms, or gastrointestinal symptoms, or orthostatic symptoms, etc. So they had a chronological basis of a broad stroke of what happened to the patient, and then were able to fill in the gaps about what the potential causes could have been of that syncope by more directed questioning. And then they would go through and ask a little bit more about basic past medical history, medications, and in ED we often would like some assessment of function, because if we're going to send patients home, we want to make sure that they're safe to go home. So they would ask about how they're going at home. And so the better students would do that chronological sequencing, some very targeted questioning, and then complete the rest of the assessment. For ECG, there was quite a so again, for ECG, the better students would have a nice structure and would come up with a good interpretation. And the interpretation was that the patient had slow AF and also had some T-wave inversion, and would give an interpretation of why the patient might be in slow AF and a good interpretation of why they might also have T-wave inversion, both of which are related to digoxin. And then the last one was differential diagnosis, which really came from that history and then investigation and having a good differential diagnosis of a patient who collapsed in terms of syncope versus seizure. And out of syncope, could it have been, it was probably the arrhythmia, but also had a broader differential as well.
Yes, and now on the other hand, what were some issues where you found students struggle a bit more?
Okay, so the main one that I found, and also my other examiners found, was poor ECG interpretation. So a poor structure and poor interpretation of what they found, or not being able to find the abnormalities, or requiring prompting. So a lot of my students needed prompting to actually show or to tell me that there was T-wave inversion when it was quite an obvious abnormality. So that's probably the main one. And that often would affect the differential diagnosis, because if you can't interpret the ECG in terms of being slow AF, then it does impact a little bit, or could impact a little bit on what you're thinking in your differential diagnosis. The poorer students in the history taking also either didn't complete the history, so they just asked about the current event and then didn't ask anything else, so they didn't really complete the history, or you could tell that they were just asking random questions almost, so there was no structure to their questioning of the patient. So they either didn't get the sequence of events chronologically, or they had random questions which weren't really directed to their differential diagnosis. So they weren't asking cardiac questions, seizure questions, etc. So it was sort of a bit of random in questioning, rather than you could see the better students were asking directed questions to try and find evidence for a diagnosis.
Yeah, that's right. I think in general, there's sometimes with histories of presenting complaints, we find also in internal medicine that students, sometimes don't get enough detail around the presentation about what actually happened, and if they were having diarrhea, how many times were they having diarrhea. So not just that they were having diarrhea, but really get some detail around symptoms. Because it does help with the differential.
Yep.
And then the second part of the history should always be asking further questions to help you weigh up your differentials. And that's what we usually like to see. And ECGs, look, there's obviously a lot of resources that we have in our LMS on ECGs. and certainly a lot of other resources that you all would be aware elsewhere. So it's good to look. There's a high chance there'll be ECGs, which will be either in the written paper or the OSCE. So good to brush those things up in the next couple of months. Otherwise, Tony, in terms of ED stations that are in the OSCE in general, are there any general hints or tips about how students, what students need to do? I think the station that we had illustrated some of those principles, but there are other ones as well.
Yeah, I think in ED we focus on a few things. So one is the undifferentiated presentation, like this was syncope. And for that, it's really about getting that information to inform your differential diagnosis. And often we will have some investigations to interpret which will help that, whether it's an X-ray or some blood tests or an ECG. The other type of thing that we focus on is resuscitation and critical illness. And we'd like for you to have first of all, a recognition that the patient is unwell, or they've got a serious problem, whether it's a serious injury or serious illness, and recognise that, and having a structured approach to that resuscitation, like an A to E approach. So, for example, and sometimes we might have trauma, and it might just be a traumatic injury, like a relatively minor injury, but we want you to work out whether that's a serious thing or not. For example, we've had previously an ankle injury, and students could determine that the ankle was broken, but they didn't really. Some of the poorer students didn't recognise that it was a serious injury, like it was ankle fracture dislocation and needed immediate reduction because there was neurovascular compromise. So there's a difference between recognising a fracture and recognising a serious injury. So I think that's one of the things, is recognising that the patient is really unwell. For some of our other stations and for some of our in-training assessments, we've had, for example, blood gases, which show a really serious injury, a serious illness. And the students can read the blood gas, but they don't give the impression that they think it's important or that it's something urgent. So I think that's the other thing in ED, is that we might give you a case where there's some urgency and you have to recognise the urgency rather than just recognise that there's something wrong with the patient.
Okay, yes. So a few more things to think about in preparing for the OSCEs in the next couple of months. Well, thanks very much for your time, Tony. Hope that the students have also found it useful to have some of those insights this evening.
Yeah, hope so. Thanks for letting me give you some feedback.
Okay, thank you.